Again, we'll pause here before moving on to the next topic. We did receive a few questions on transitional care management, and again, we will take those questions and have those posted to the site. And please continue to send in other questions. Okay, moving on to ordering of portable X-ray services by non-physician providers. This has been a topic of some question by Academy members, and this is a development and a provision and an improvement that the Academy supported on your behalf. Effective next year, nurse practitioners, clinical nurse specialists, physician assistants, etc., will be able to order portable X-ray, again effective January 2013, where the ordering of the portable X-ray services is within the scope of your practice under state law. And again, this is very congruent with other services that you're already ordering, and this is really what was recognized by CMS, that this variation existed, and to CMS they were just making this consistent, even to the recognition that there were more extensive services that you're ordering from a diagnostic perspective, and yet you could not, in terms of nurse practitioners, physician assistants, and CNSs, could not order the portable X-ray. Some of the benefits of this new provision effective January 13 is that it rationalizes the ordering and interpretation with other diagnostics. As we know, it enhances access and convenience for the patient. Provides payer savings due to the in-home service versus transport and cost to outpatient facilities and cost for the service. It increases your practice revenue based on the non-physician provider ordering and interpretation. It increases the value of the non-physician providers within practices, and then overall from a house call practice perspective, it increases the value of home care medicine practice across the medical care continuum and delivery for that ability. The next page includes some of the language from the CMS rationale that was included in the final rule for 2013, and you see that what's provided here is that we believe non-physician practitioners have become an increasingly important component of clinical care, and we believe that delivery systems should take full advantage of all members of a healthcare team, including non-physician practitioners. Further, allowing limited license and non-physician practitioners to order portable X-ray services within the scope of their practice will enhance the role of those practitioners. And again, the Academy supported this provision in the proposed rule, and we're pleased to see that was included in the final rule. There is some audit language we want to bring to your attention, and then some recognition of some of the existing audit concerns that CMS notes as well. CMS will take a look at volumes and ordering of services, and at the bottom of this slide, as they indicate, as with any diagnostic test, they want to make sure that you proactively determine and document the medical necessity for testing. And of course, this applies to all the services that are ordered. So they did add this language in the final rule. And as many of you may know, there was an OIG report that did note the discrepancy, the variation in coverage for the portable X-ray services, and also the fact that some contractors were paying for the service. And there was a report about this a couple of years ago, and that's on the slide that you see posted now. In the final rule, they note that CMS should continue to recoup payment for portable X-ray services identified under the report as ordered by limited licensed physicians and non-physician practitioners. And they would, and that CMS would continue recoupment efforts in response to the OIG report. However, they continue that they've instructed their payment contractors that the ordering of portable X-ray services should not be made a priority for additional medical review activity beyond claims identified in the OIG audit. So again, this is a recognition that there were services identified in that report that were paid when they should not have been paid. However, they are moving into a new environment, and we'll hopefully keep that balance in mind. I want to move on to a different topic and a different payment system onto the state level. An increase of Medicaid payment rates to the Medicare fee schedule allowable for 2013 and 2014. This is not a feature of the Medicare final rule for next year. This is a element that was included in the Act of a couple of years ago. Payment by state Medicaid agencies is to move up to at least the Medicare rates in effect for each of the 2 years, 2013 and 2014, or that rate that would be in place applying the conversion factor that would have been in place for those states using the 2009 Medicare conversion factor. So whatever will be the higher rate, the 2013 versus 2009, and then in 2014 that year, or 2009 Medicare conversion factor again. What services are involved? Again, strictly speaking from a Medicaid perspective, these are primary care services furnished by a physician, and I do want to note, or under the supervision of a physician with a specialty designation of family medicine, general internal medicine, or pediatric medicine. So nurse practitioners and physician assistants can render these services and have them recognized for the additional payment. However, those services rendered would have to be under the supervision relationship with a physician. Physicians self-attest that they are either board certified, recognized by the American Board of Physician Specialties. We'll get into the specialties that are involved in the next slide. The American Osteopathic Association, or the American Board of Medical Specialties. And then we'll discuss the specified E&M and vaccine administration codes that are involved under this change for 2013 and 2014. The physicians, again, or the services rendered under the supervision by a physician would be those in family medicine, general internal medicine, pediatric medicine, or one of the subspecialties within those primary care specialties. So pediatric cardiology, for example. And again, that may not be relevant to our Academy members, but that's just an example used in the Medicaid rule discussing this payment increase. If one is not board certified, then they would look to see that 60% of your Medicaid services, claims submitted or paid, were provided in a managed care environment. Again, if you're not board certified, or if you're a new physician coming in 2013 or 2014, are for the specified evaluation and management codes and vaccine administration codes. So what are those codes that are subject to the increase? Those are codes that do include house calls. And then the vaccine administration codes are listed here. For a couple of logistic points here, if a state or a managed care entity is going to pay for the increase in rates for 2013 and 2014, they need not do so on a fee-by-fee basis, but they can make those additional payments in lump sum payments. CMS makes the requirement that that be done no less than quarterly. Again, this increase in payment is not applicable to the primary care incentive program, and it does not apply to other incentive payments. So, for example, the addition in payment would not go against the percentages under electronic incentive payments. bonus payments. Again, further listing of the, if codes are paid by on a state level that are evaluation and management services, but are not paid by Medicare because they were not part of the Medicare program, what Medicare will do is to pay Medicare-like rates in 2013 and 2014 for CPT codes that are not reimbursed by Medicare, but they have been recognized and paid by state Medicaid programs. And up here you have a listing of the types of codes that are would be involved and paid via a Medicare-like value establishment and conversion factor approach. So when will these services, the additional payments, come online? By the final rule of November from CMS, these payments, the additional payments, are to be in place as of January of next year. That said, however, states have until March 31 to submit a state plan amendment that would be retroactively effective to the beginning of the year. They state that it's common practice for states changing payment rates to make retroactive adjustments to claims after that state plan amendment has been put into place. And then they recognize that additional time for states to make system changes to reflect this final rule. Again, this Medicaid rule came out beginning of November, and then also the November publication of the Medicare RVUs. In other words, the rate increase is effective. We would recommend that you, for the straight Medicaid beneficiaries that are part of your practice, that you well document those patients and that you put in systems in place to be able to account for those services and to be able to record and present those differences not only to state agencies but also to manage care plans for reasons I'll discuss in a moment. Application to dual eligibles and other populations is discussed in the rule. Medicaid requirements applicable to claims or services who are dually eligible are not changed by this rule. States have to continue to comply with all requirements for payment of claims for services provided to Medicaid beneficiaries who are also eligible for Medicare. The bad news in this rule is that there isn't the good news that Medicaid programs are required to pick up the 20% co-payment above the Medicare allowed. The example used in the final rule is presented here. If we see a Medicare allowed amount, what's called the 80% of the allowed amount, the Medicare cost sharing amount would be $80. If the Medicaid rate in a state is $75, the Medicaid, and Medicare has already paid you the $80, the Medicaid program then does not have to pay the $20 above, because the amount that Medicare paid is higher than the Medicaid rate in effect. What this requirement is basically doing is bringing up the Medicaid rates up to the 80% level of the Medicare allowed, which is a huge improvement for those of you seeing Medicaid patients in states where there's such a great variation in payment, though. Moving again, application to dual eligibles and other populations. The final rule, final Medicaid rule in this regard, notes that special need plans are really Medicare plans and are not subject to the requirements of this rule. States are responsible for ensuring that payments for Medicaid enrollees of special need plans reflect the appropriate payment increase. Services provided in FQHCs, rural health clinics, and other departments that are not paid on a fee schedule basis are not eligible for this higher payment. nor are services provided in nursing facilities that are reimbursed on a per diem rate. 1115 waiver services are subject to this regulation for additional payment if your services are paid under a fee schedule. What happens if you're paid on a capitated basis by a managed care plan? Basically, the points on this next slide state that the state and the managed care plans have to document to CMS that you're being paid the additional value. So your capitation rates for the evaluation and management services would be converted in essence to a fee-for-service methodology, and then effective for next year, there's the expectation and there'll be the monitoring that you'd be paid the additional amounts. That would be the difference between those capitated levels and the levels required to bring up to the 80% of the Medicare fee schedule. There's a lot of mechanics in place in this slide, and that would take place between the payments from a state to a health plan and then to your to delivery systems or to networks with whom you contract, and that'll take some time. Again, would recommend that you thoroughly document your encounters and your evaluation and management services and your tracking of those on a CPT basis to health plans, including those that you receive capitated payments. And there is the requirement that you do get paid for that additional value between those capitated rates and the rates that would be in place if those were converted to the 80% of the Medicare fee schedule. Those are the revenue opportunities we wanted to discuss this afternoon. There is one medical review item that was included in the final rule regarding the Medicare contractors performing non-random prepayment complex medical review. There was a requirement that there be some finality to these non-random prepayment complex medical reviews, and that there be a way of determining when those reviews or the cases essentially would be closed. However, the Patient Protection Act of a couple of years ago repealed the requirement for CMS to establish that termination time frame. And again, this is just one of the many medical reviews that CMS or CMS contractors render, but this was a feature of the final rule, so we just wanted to note that. And given the repeal, the CMS position is that contractors terminate each medical review when the provider or supplier has met all Medicare billing requirements as evidenced by an acceptable error rate as determined by the contractor. The Academy thought that was a bit arbitrary and vague, and it argued for what was in the Act of a couple of years ago, but that's not what decision CMS has reached. Some of the questions that have come in we'll go over. I will tell you that these questions have been received, and again, if we can't respond to them real time, we'll get the information or the citations out to everyone and post it either listservs through the electronic newsletters and also in Frontiers. Why can a clinical psychologist order an X-ray and not a Master's of Social Work? Some of that, again, may have to do with the state scopes of practice and the types of services through training programs, et cetera. We'll take a look at that and see if that's discussed in the final rule. The transitional codes are in effect January of next year. So again, that's why we'd want you to again get familiar with those. This session will be posted on the site. And we'll make sure that your documentation systems, electronic health records, and your practices, and in fact, including your staff and other services that have to do with the services are in place January of next year to make use of this opportunity, which is really paying you for services that you're likely already rendering. Definition of under supervision by a physician for house call services. Does the physician have to be on site with the NP or PA? No, that is not the case. That would be evidenced by the collaboration agreement in place. And again, under supervision in this regard should not be confused with incident to. And incidents to services are not services where house calls where there's an effective use, because that envisions being within the same sort of office structure, and that's really not in place for the house call practice. But under supervision by a physician really has to do with the collaboration agreement. The additional payments from Medicaid to podiatry, I'll confirm that. My belief is that podiatrists are going to be included well, rendering. Again, it has to do with the it has to do with the codes that are rendered. But we will take a look at the designation of podiatry. But again, it is for the designated evaluation and management and vaccine codes. Transitional care, the expectation of more referrals by home health agencies. We would think that this would be really a tremendous benefit to house calls in general in your relationships with hospitals and growing your practice. Home health agencies certainly would help those relationships. You're seeing patients that may need home health agency services, and if that wasn't ordered or picked up in the hospital environment, again, your services may identify that need. Once the patient is at home, though, just to note that this involves the transition from the hospital setting. So if the patient is already home when you're encountering the patient, and if it's outside of those windows, outside of the 14-day for the high complexity, and if you haven't had that contact within the 2 days, or the contact within 7 days for the high complexity, or the 14 for the moderate complexity, then the code is essentially not in effect. Where you may be getting additional referrals from home health agencies is if they understand or know that the patient is being discharged, and you're getting that contact from them and that sense of awareness of the patient. And so as the patient is transitioning from the hospital to the community setting, then certainly there is that opportunity for increase in home health agency referrals. For CPO, there needs to be documentation of time. I'm glad this question came up. Does there need to be a documentation of time for these codes for the clinical staff? There was a valuation of time to establish the work values and practice expense, et cetera, for these codes of nearly an hour for both codes of work RVUs. However, in the final rule, we're not seeing the delineation of time that you see in documentation required of CPO. We're before the manual process, though, where CMS would be giving instructions to its contractors as to how to ascertain documentation and adjudicate claims, though. So we will keep an eye open for that in the future. However, at this point, we do not see that precise identification of time that you have to document now that relates to CPO. Do you have to bill the CPO within the 30 days of that visit? Actually, the reverse is the case with this code. It's within that first 30 days when these codes, the transition care management codes, are essentially alive, that the CPO cannot also be billed in that first 30 days post-discharge. However, the CPO can be billed, as usual and routine after those first 30 days. And again, there isn't a requirement to use these codes. This is a new service identified through the CPT process, covered and recognized for payment by the Medicare program. Can an MSW provide the service, or only an RN or PA? These services on the clinical side would be by the providers recognized on the Part B basis by the Medicare program, physicians, nurse practitioners, clinical nurse specialists, physician assistants, etc. We'll drill down to the others and post about the other limited licensed professionals. Can you bill for a new patient visit and transitional visit within the same month? Again, that's where I was saying that there is that requirement or the rule about being in a different specialty if the patient was seen in your practice in the past 3 years. So this might make sense for practices that do have different specialists. Actually, now that I'm thinking about this, since this is not a new or an established patient visit code, I want to take the opportunity to perhaps to do a little bit of research about that and post a response to that question, because that's a very important question. If you satisfy the level of code, can you bill earlier than at day 30? Our understanding right now from the language in the final rule is that since they only want to receive one claim for that patient by one provider to adjudicate and pay, that they will only receive and accept the claim after the 30 days. So the answer to that question seems to be pretty clear in the final rule, that the claim submission has to occur after the 30 days. We did receive some additional questions. I just want to acknowledge that they've been received, and again, we will research these and post the responses. I was using the examples in the handouts were just examples just to illustrate differences in dollars. That didn't come out of the final rule. Yes, we would recommend you add these codes to your super bills, the 99495 and 496, and get your systems ready. Actually, all through your systems, through your electronic health records, your revenue cycle, with your vendors, to your clearinghouses, et cetera, and to that G0454. Absolutely start educating your staffs using this material, and get those on any paper or electronic super bills. The billing of CPO and these claims, the 99495 or 99496, within that first month, yes, those and some additional care coordination codes are mutually exclusive, but again, within that first 30 days only. Can they be used for patients under hospice? Again, hospice CPO, again, is excluded, but if this involves the transition from a facility to hospice that's community-based, then the code could be used. The Medicaid payment changes, Medicare, primary Medicaid, are you losing the Medicaid 20% coverage? If that coverage is in place now, you wouldn't be, to our understanding, it's not a losing of that opportunity, rather it's an increase of the base Medicaid rates up to the 80% of the Medicare allowed. Want to thank all of you for attending this afternoon and for the questions. Again, we will post the webinar, and we'll also research and post all of the questions that have come in. And again, thank you for joining us this afternoon. And we're pleased to present this information that should help all of our practices for next year. Thanks again.